Hello, everyone, and you're very welcome to this HRB webinar, which is part of the Evidence for Policy series. And today, our topic is Growing Up in Ireland, Factors Associated with Cocaine Use in Adolescence and Early Adulthood. My name is Dr. Claire O'Connell, and I'm delighted to be your host in a session that will feature presentations from Dr. Deirdre Mongan and Dr. Margaret Brennan, and we'll have a panel discussion and a Q&A afterwards. As well as hearing from Deirdre and Margaret, we will also be joined by Professor Bobby Smyth, and I'll introduce everybody more fully in due course. But I just want to thank everybody today for their time and expertise. Now, a spot of logistics. The live audience will have the opportunity to ask questions through the Slido platform, which is www.slido.com. And the access code, the magic numbers there are 2679553, and you'll see those details in the chat as well. Live captions have been enabled for this webinar and should be available to anyone who would like to use them. Now, on to business. It is a pleasure to introduce our first speaker. Dr. Deirdre Mongan is a research officer with the Health Research Board with responsibility for the Irish National Drug and Alcohol Strategies. Deirdre has recently been analysing through Growing Up in Ireland 1998 child cohort dataset to measure the extent of substance use among young people in Ireland and to explore factors associated with substance use. And Deirdre is going to present to us today an overview of cocaine prevalence and related trends in Ireland over the last 20 years. And it's based on findings from the recently published paper, Trends in Cocaine Use and Cocaine-Related Harms in Ireland, a retrospective multi-source database study. So over to you, Deirdre.
Thank you. And if everyone can see this, I'll start. First of all, welcome to everyone and thank you for joining us today. And as Claire said, I'm going to talk about trends in cocaine harm in Ireland since 2000. And before I start, I'd just like to acknowledge my co-authors on this study. So before I start talking about cocaine use in Ireland, just want to show you the two studies that the presentations are based on today, and these can both be accessed through open access at the HRB National Drugs Library. So before I talk about cocaine use in Ireland, I'm going to talk a little bit about cocaine use at both the global and European level. So based on information from the United Nations Office for Drugs and Crime, global cocaine supply is at a record high, with Western Europe alongside Central Europe and North America being the largest destination markets for cocaine. We know that cultivation of cocaine doubled between 2013 and 2017, peaked in 2018 and rose sharply again in 2021 and still remains very high. And this is helped by the fact that the process from coca bush cultivation to cocaine hydrochloride has become increasingly efficient. And in the 10-year period between 2013 and 2023, the number of cocaine users worldwide grew from 17 million to 25 million, and that's an increase of about 50%. So moving on to European cocaine trends. So in 2023, across Europe, 419 tonnes of cocaine were seized in the EU. And this was the 7th consecutive year that seizures exceeded previous records. And we've seen similar trends here in Ireland also. Between 2023 and 2024, cocaine residues in wastewater increased in over half of the European cities that participate in the European-wide network that's known as SCORE. Dublin took part in this study for the first time in 2024 and ranked number 19 out of 132 for cocaine residues in wastewater. In 2023, cocaine purity across Europe ranged from 17 to 93%, and this level is 34% higher than in 2013. So the cocaine that people is using is becoming more pure. And finally, while the price around us, price of everything seems to have increased in recent years, the price of cocaine has actually decreased in real terms by 12% across Europe between 2013 and 2023. So, given the reports on increased cocaine use in Ireland and the increase in harm indicators such as treatment entrance, we undertook this study to look at trends over time to using a range of indicators to measure the extent of cocaine use and cocaine harms in Ireland. So to measure cocaine use, we analysed data from general population surveys on drug use, and to date, 6 surveys have been undertaken since 2001, and these are undertaken every 4 to 5 years, and these provide population prevalence data on cocaine. To examine the health-related impacts of cocaine use since 2000, we analysed a number of national health information systems. So in total, we analysed 4 systems. These included the Hospital Inpatient Inquiry Scheme, where we looked at cocaine-related discharges from acute public hospitals. We analysed the National Psychiatric Inpatient Reporting System to look at cocaine-related admissions to public and private psychiatric hospitals and units in Ireland. We analysed data from the National Drug Treatment Reporting System, and this is the National Register of Addiction Treatment in Ireland. And finally, we analysed the National Drug-Related Deaths Index, and this is a complete census of drug-related deaths nationally. So the HYPE system, this is managed by the HSE Healthcare Pricing Office, and the other 3 systems are managed by staff at the HRB. So moving on to our results. So this slide presents trends in last year cocaine use since 2001. And we can see that between 2002 and 2006, there was a significant increase in cocaine use from 1.1% of the general population to 1.6%. Cocaine use stabilised or decreased slightly between 2006 and 2014. However, we can see quite a significant increase between 2014 and 2019, when cocaine use increased from 1.4% to 2.3%. And in the 2022-23 survey, the rate of cocaine use among the population in Ireland had stabilised. However, we are now among the highest users of cocaine in Europe, and this is particularly the case among 15 to 34-year-olds in Ireland. So I'm going to talk you through this slide. There's quite a lot going on, but this presents the trends in acute hospital discharges that relate to cocaine use between 2000 and 2023. So back in 2000, the rate of discharges per 100,000 of the population was just 1.4 per 100,000 of the population, and this corresponded to 54 discharges in that year. However, we can see that by 2023, this had increased considerably to 24 discharges per 100,000 of the population, or just under 1,300 discharges. If we take the average annual increase between 2000 and 2023, the average annual increase was 13% per year. However, if you look at the graph here, there are a lot of fluctuations and trends. So firstly, we see between 2000 and 2007, a large increase in the number of discharges, albeit from a very low base. The join points in this graph represent when significant trends or significant changes in trends occurred. We see, though, that this was followed by a significant decrease in the number or the rate of discharges between 2007 and 2012. So during this time period, the average percentage decrease of cocaine discharges was 17%. However, we see after 2012, the trend changed again, and we see quite a large increase all the way up to 2020. Since 2020, we see that discharges have already levelled off, albeit at a very high level, and the highest that we have recorded since 2000. So moving on to cocaine-related admissions to psychiatric hospitals, and we can see that the trends are similar to that from that we saw in acute hospitals. So back in 2000, the rate of admissions was just 0.2 per 100,000 of the population, or under less than 10 admissions that year. However, by 2022, this had increased 12-fold to 2.4 per 100,000 of the population, and this represents 123 admissions in this year. Between 2000 and 2022, the average annual increase was 11%. However, we can see fluctuations in the trends across that time. And again, we see between 2000 and 2006, there was a significant increase in the rate of admissions. We then see a decrease between 2006 and 2011. And then this is followed again by quite a large increase all the way up to 2018. And between 2011 and 2018, each year the rate of admissions increased by 28%. And similar to what we've seen with the HYPE data, we see a levelling off of cocaine admissions from 2018 onwards. So this slide shows the trends in the number of cases attending treatment who reported cocaine as their main problem drug. And again, quite similar to trends to what we've seen already. So back in 2000, the rate of treatment cases was just 1.5 per 100,000 of the population, and this corresponded to 57 cases that year. However, by 2023, we see a huge increase, and by 2023, the rate was 93 per 100,000 of the general population, or just under 5,000 cases. So that is quite a considerable increase in quite a relatively short period of time. The average annual increase across the 23-year period was 18%. However, again, we see fluctuations in the trends. So between 2000 and 2007, there was an average annual increase of 35% in the number of cases each year. But again, this was from a very low base. We see a small decrease between 2007 and 2013 of just 3% of a decrease each year in that time period. However, since 2013, we see a very large increase in the number of cases presenting to treatment with cocaine as a main problem drug. And unlike what we're seeing with the HYPE data and the psychiatric data, this has not leveled off yet. So we don't know if the figures we see in 2023 represent a peak or not. So the final data set was the NDRDI, and where we looked at trends in cocaine mortality from all causes. In the report, we've also presented findings in relation to cocaine mortality from poisonings, and the results are quite similar to that from what we see for all causes. So we can see back in 2000, the rate of deaths was 0.3 per 100,000 of the population, and this corresponded to just 11 deaths in 2000 relating to cocaine. However, by 2020, this has increased to 5.6 or 278 deaths. And this corresponds to an average annual increase of 17% each year in the rate of deaths. However, again, we can see very clear fluctuations and trends. So between 2000 and 2006, the rate of deaths from cocaine increased significantly and quite steeply. And for each year, the average percentage increase was 49%. We see quite a steep decline in the number of deaths between 2006 and 2011, and the average percentage decrease during this time was 13%. However, similar to what we've seen already, we see a large increase of between 2011 and 2020, and the average increase across this time was 17%. And similar to the data we have from the NDTRS, we don't know yet if this is a peak or not, or if cases will continue to rise. So just to give an overview from the four sources, and we can see that the trend in cocaine harms across the four information systems are very similar since 2000, with increases from a low base between 2000 and 2006 or 2007. We see then that levels of harm decrease in all sources from 2007 to about 2011 or to 2013, but since then there's been a large increase in cocaine-related harm. And to some extent, these trends mirror those of the Irish economy. So the early 2000s, as you may well remember, coincide with the Celtic Tiger era. This was followed by a deep recession beginning in 2008, when unemployment rose sharply before peaking in 2011. And males and young adults were disproportionately affected. And these would typically be the populations that would be most likely to use cocaine. However, the recession in Ireland also coincides with large market changes. And during this time, there was also large reductions in the amount of coke available to be converted to cocaine in Colombia. And this was due to intense spraying and due to a large increase in manual eradication efforts. However, since 2013, we see in relation to the economy began to improve in Ireland, and we see that cocaine harms also rise during this time. And However, while the trends for cocaine-related harm track those for Ireland's economic status until the mid-2010s, given the continued and sustained increase in harms observed since then, it is likely that other factors, probably market factors that are also at play, that have contributed to the increase in cocaine-related harm in Ireland. So, to conclude, multiple Irish data sources demonstrate increased levels of cocaine-related health harms. And cocaine has now moved from being of minimal significance from a public health perspective to being a major problem. And this has happened over the course of about 20 to 25 years. Responding to cocaine-related health problems and prevention efforts focused on cocaine constitute a public health priority. And continued surveillance of trends in Ireland and internationally are required to see if these trends continue to increase or if they will level off. At this stage, I just want to thank you all, and I'm going to hand over now to Margaret, who's going to talk about the findings from her analysis on the Growing Up in Ireland data.
Thank you, Deirdre. Thank you for that really fascinating presentation. Some very important trends in there, some very steep ascents in those graphs as well. I'm certain we'll have loads of questions about those later on. If you do have questions, please put them into Slido. You'll see the details in the chat there. You just go onto the website, put in the access code, and you can put your questions in for the Q&A later. For now, though, I would like to invite Dr. Margaret Brennan to present. Margaret is a clinician researcher. She's currently doing higher specialist training in public health medicine, and she's part of the HRB-funded Irish Clinical Academic Training PhD programme, which many people will know as ICAT, and she's based at Trinity College Dublin and the National Health Intelligence Unit. Margaret is going to discuss findings from the recently published paper, Factors Associated with Cocaine Use at 17 and 20 years old, a longitudinal analysis of a nationally representative cohort. Over to you, Margaret.
Thanks, Claire, and thanks, Deirdre. So thanks for the opportunity to present here today. As is said, my name's Margaret, and I'm a public health doctor currently working between the Health Intelligence Unit and Trinity College Dublin. And today I'm going to present the results of a study that I worked on year before last now, time flies, that investigated factors associated with cocaine use at both 17 and 20 years old using the Growing Up in Ireland cohort. And I worked on this study with a lot of great colleagues who are listed on screen, including Deirdre and Bobby, who are both panelists today. And I think I also saw that Sean Miller and Brian Galvin are also on the call. So why did we focus on cocaine? Well, it became clear that this is an important topic for a number of reasons. Ooh, I think I'm experiencing the same issue. There we go. Internationally, it became clear that the prevalence of cocaine use was increasing. This graph, which is from the 2023 UN Office on Drugs and Crime report, focused on cocaine, shows increasing trends in both self-reported prevalence of use and estimates of consumption based on wastewater data for Western and Central Europe between 2010 and 2021. And globally, it was estimated that 22 million individuals worldwide use cocaine in 2021. When prevalence was broken down by country, we could see that Ireland, just moving around my speaker bubble, Ireland actually had the fourth highest rate of cocaine use globally at 2.4%, while Australia was the country with the highest past year prevalence of 4.2%. So why does this matter? Well, the harms associated with cocaine are well recognised. This paper, which is from 2007, so a little on the older side, but nonetheless remains relevant. This paper ranked cocaine second only to heroin in terms of physical harms, dependence, and social harms. Cocaine use is causally associated with mortality related to cardiovascular pathology, accidental injuries, and homicides, and morbidity associated with mental health disorders. Really importantly, cocaine is thought to have a relatively fast onset of dependence, and it has been estimated to affect 5 to 6% of users within the first year of use. Importantly as well, health harms are not limited to chronic users. Short-term and even first-time use has been associated with serious health consequences such as seizures, strokes, and rhabdomyolysis. Coming back to the Irish context, which Deirdre has covered in great detail, so I won't labour this point, but I suppose a big driver for choosing the topic of this paper was the concerning trends we were seeing in drug treatment related to cocaine. In 2022, cocaine became the leading drug for which individuals sought drug treatment in Ireland, surpassing opioids for the first time and accounting for 34% of all drug treatment cases. And this upward trend continued in 2023, where cocaine actually accounted for 38% of all drug treatment cases. And when we looked at it by age, we could see that the number of cases presenting related to where cocaine was deemed to be the main problem drug was highest in the 20 to 29-year-old age group, although it continued to account for a substantial proportion of the cases presenting in later years. So these trends were clearly concerning, and we wanted to understand a bit more. In terms of the evidence gaps we were specifically interested, when I looked at the literature, I realized we really didn't know much about when cocaine use typically began among young people in Ireland. And internationally, there was actually really limited longitudinal evidence on risk and protective factors that were associated with subsequent cocaine use among young people. So we decided to address these gaps. Our research questions were, what is the prevalence of cocaine use at 17 and 20 years old in a general youth population? And second, what are the risk and protective factors that were longitudinally associated with cocaine use at both 17 and 20 years old? To address these questions, I used data from a study that many of you might be familiar with, the Growing Up in Ireland Cohort 98. So this is a nationally representative cohort who were born between 1997 and 1998. And the primary aim of the study was to provide evidence that can be used to inform government policy in relation to children, young people, and families. The initial sample size in this study was 8,568 9-year-olds, which is a really large cohort study and actually represented 1 in every 7 9-year-olds who were resident in the country at the time. And perhaps you're all familiar with it, but I think it's an important point to emphasize just the way in which they sampled the Growing Up in Ireland study through the primary school system and ensuring that they had appropriate representation within the sample of particular characteristics such as sex, socioeconomic status, geographic region, means that this study population can be considered representative of the broader population of young people who are born in these years. So this is a very powerful study design. And there were now, at the time of starting this study, there were 4 waves of data available for analysis at age 9, 13, 17, or 18, and 20 years old. So we had a lot to work with. The design of Growing Up in Ireland was informed by Bronfman Benner's bioecological model of human development, which basically says that the outcomes that individuals experience are the result of a complex interplay between individual, family, social, and environmental factors. So we were informed by this theory when we selected our exposure variables. And we selected these exposure variables, which you can see within the image on the right of the screen, in advance of starting of our analysis, so a priori. Our outcome of interest was instant past year cocaine use, which was defined as the first report of past year cocaine use at either 17 or 20 years old. And we investigated this separately in 2 different models because we were interested in understanding whether the same risk and protective factors were relevant at each age group, within each age group. To examine these associations, I used survey-weighted logistic regression models using generalized estimating equations. Okay, so I'll just move on to the descriptive results. So this graph presents the prevalence of past year cocaine use at age 17 in orange and age 20 years old in pink. And we found that at age 17 within this cohort, cocaine use was relatively rare, 4% of participants reported use, but that this increased really substantially by the age of 20, when 23% of participants reported use of cocaine in the past year. And just to re-emphasize again, this is 23% of participants at age 20 within this cohort, but this can be generalized to the broader population of 20-year-olds who were resident in Ireland at the time of which this was sampled. So, nearly a quarter of all 20-year-olds is really, really sizable. We were also struck by how steep the relative increase was. So between ages 17 and 20, there was a 475% relative increase in the use of cocaine over just a 3-year period. And the last descriptive result that stood out to us was that over 75% of those who reported using cocaine at age 17 continued to report use age 20. So what we took from this was that those early users are potentially likely to exhibit a sustained pattern of use, which is obviously concerning because a chronic pattern of use of cocaine, an individual engaging in such is much more likely to experience health harms. Moving on to the regression results. As I said, I examined individual, family, and socio-environmental factors that we hypothesized might be associated with instant cocaine use at age 17 and 20 years old in two separate models. So I've got the results for the model looking at cocaine use at 17 years old in the middle of the screen and 20 years old on the right-hand side of the screen. And the result, this table was rather large, so it's split over two slides, but all the results I'm presenting to you were run together. So this table is the first half of the results, which focuses in on the individual factors. And I'm not going to mention everything we analysed here. I'm going to highlight a couple of them that we thought were particularly interesting. So the first thing that stood out to us was male sex. So male sex was associated with elevated odds of cocaine use at both 17 and 20 years old, but the effect estimate was much larger at age 17 than at 20. Males nearly double the odds of cocaine use at 17 versus a 40% increase in the odds at age 20. Next, having had internalizing symptoms, which are things that might be considered similar to symptoms of anxiety, depression, or peer problems, was actually associated with reduced odds of cocaine use at both ages, although the effect estimate was only actually significant at age 20. And we can't say what are the exact reasons for this, but we hypothesize that potentially those who experience internalizing symptoms may be more likely to have an aversion to risk or potentially experience problems with peers, as we know that cocaine is typically used socially. The next association that stood out to us was age at first alcoholic drink. So this is a really strong association that we saw between the age at which you first drank alcohol and your subsequent risk of cocaine use. And so particularly for those who used alcohol earliest, so defined as at 14 or younger, this was associated with an 8-fold increase in the odds of cocaine use at 17 and a 19-fold increase at the age of 20. One interesting difference that we noticed between the models here was with the exposure to the Drumcondra test, which we use to represent academic ability. So I'm sure most people on this call are familiar with the Drumcondra reading test. It's a standardized test that Irish children take at the age of 9. And what our results suggest is that children who scored in the lowest tertile of this test at age 9 had reduced odds of using cocaine at age 20. But at age 17, we didn't see this significant result, but we did note that the effect estimate is in the opposite direction, potentially suggesting, some differences between the cohorts of individuals who begin to use cocaine at an earlier age versus those who use at age 20. Moving on to the second half of these models. So once again, the results for the 17-year-old model is in the middle and 20 years old on the right-hand side of the screen. Starting off with, at the top, familial alcohol use disorder, drug use. This is associated with a 2-fold increase in the odds of cocaine use at 17, but actually wasn't significantly associated at age 20. So again, some potential differences emerging here. This was the other very strong relationship that we observed here. So having friends who used cannabis at age 17, this was associated with a 7-fold increase in the odds of cocaine use at 17 and a 2-fold increase in the odds of cocaine use at 20. Lastly, growing up in a neighbourhood where substance use was common, as reported by parents, this is associated with a 2-fold increase in the odds of cocaine use at 17, but again was not significantly associated at age 20, again suggesting that this may be a unique risk factor for early cocaine use. So just to try to bring this all together, in this study, we found that nearly a quarter of 20-year-olds in this nationally representative cohort report cocaine use, leading us to wonder, is use of cocaine in this age group increasingly normalised within the Irish context? When I looked at the literature, it was striking that this estimate was substantially higher than most international estimates, which typically range between 3 and 16% among this age cohort. Although I will caveat that by saying some of the published estimates are based on older data, so it is possible that similar transitions may be occurring in other countries. The estimate that we report is similar to that which was found in a study performed in University College Cork in a similar time period, which just focused in on university students. We were also particularly struck by the steep increase in use of cocaine during this key developmental stage between 17 and 20. This is a stage when individuals transition from adolescence to young adulthood, and I suppose it's a concern as potentially cocaine use for some individuals may have the potential to disrupt important transitions and potentially alter life course trajectories. Another finding that we thought was particularly important were the high levels of sustained use at age 20 among those who had started using cocaine earliest. This group of young people are likely to be at particularly high risk of experiencing adverse outcomes related to cocaine use and need to be prioritised from a prevention or harm reduction perspective. We hope that the associations described with individual, family and socio-environmental factors may prove useful to guide potential interventions in childhood and early adolescent years. Just to briefly touch on the strengths and limitations. So in terms of the strengths, as I've mentioned, once reweighted, this cohort is considered nationally representative, meaning the results we describe here today can be generalised to the source population of young people in Ireland. Second, the study population was really quite large, which allowed the inclusion of a comprehensive set of individual, family, social, and environmental factors in the multivariable models. And the study design was longitudinal, which allowed characterization of temporal relationships, which is a key Bradford Hill criterion. However, like every study, this study also has some limitations. Like many cohort studies of young people in particular, growing up in Ireland has experienced differential attrition over time. Socioeconomically advantaged individuals were much more likely to remain engaged with growing up in Ireland over the course of the 4 waves. So I use survey weights to account for this. Second, cocaine use was assessed using the measure past year use, which doesn't distinguish between short-term versus sustained use or indeed a full substance use disorder. But as already mentioned, we did observe high levels of sustained use among those who started using cocaine at 17 years old. Third, given the observational study design, there's always potential for residual confounding from unmeasured factors. And lastly, our outcome measure was a sensitive outcome, a self-report of an illicit drug use. This raises the possibility that underreporting may have occurred, which could mean that the true prevalence of cocaine use is actually higher than reported in this study. However, we hope that the trust built up between participants and Growing Up in Ireland over time and the Growing Up in Ireland confidentiality clause may mitigate this risk. To conclude, clearly cocaine use is a growing public health issue in Ireland and internationally. Addressing this important public health issue is likely to require multi-level interventions looking to reduce availability, to address antecedents, provide treatment for those who are affected, engage in public communication about the trends we're seeing and the potential risks associated with use, as well as a continued need for ongoing surveillance and further research, as this topic has been underexplored in the literature. In terms of dissemination, I've presented this study at a number of academic conferences, at policymaker events, one of which was attended by the Minister of State with responsibility for the National Drug Strategy, which we were delighted about. And the full paper has been published in an international peer-reviewed journal, the Journal of Adolescent Health. So if any of you are interested, you can have a read there. And lastly, most recently, we were delighted to see the study being picked up by an international forum, the Recovery Research Institute, and shared on their website. Thanks again to all my co-authors and to the Health Research Board of Ireland for funding this work, to the Growing Up in Ireland study, that's the acknowledgement for the Growing Up in Ireland study, and most importantly to the young people and families who took the time to participate in Growing Up in Ireland and to share their data with all of us. And thanks to all of you for listening. I look forward to the discussion.
Thanks very much, Margaret. Another excellent presentation. And you're absolutely right to thank all the participants of the Growing Up in Ireland study. It's such a rich data set, isn't it? We're absolutely blessed to have it in Ireland. Lots of food for thought there. Please do get your questions into the Slido. This is your opportunity to ask our panelists questions, and lots of discussion for that. And with that in mind, I'd like to welcome another expert to join the chat. Professor Bobby Smyth is a consultant child and adolescent psychiatrist and a clinical professor in Trinity College Dublin. And Bobby, you were involved in both of those studies that we've been hearing about today. So to kick off our discussion, could I ask you for a few of your insights and reflections from what we've been hearing about this lunchtime already?
Yes, thanks, Claire. I suppose first of all, kudos to Deirdre and to Margaret for two really impressive pieces of research. While I suppose I was involved as a co-author in both papers. It was very much Margaret and Deirdre who led on both projects. Reminds us again, I suppose, of the rich data sources that we do have actually available in Ireland, and it's great to see them used in this way. Cocaine as an issue is one, I suppose, that everyone with any interest in the area of drug use and addiction has been more and more aware of over the last decade or so. And Deirdre's data shows that I suppose we haven't just been imagining the growth in this problem. It's been very dramatic over that period. Just to say though at the outset, maybe I work with under 18s, and the addiction problems related to cocaine in under 18s isn't something actually we've seen a huge increase in. It's definitely nudged upwards, but the big increase seems to be in that young and even older adult age range. And maybe that's outlined in Margaret's paper, where she sees that jump from age 17 to 20. That seems to be a key period for entry into the world of cocaine use. The cyclical nature of the harms demonstrated by Deirdre is really fascinating, and that may be linked to changes in the supply network internationally or globally. But it is interesting to see that it does seem to tally with the economic changes that we've had in Ireland. And again, going back to why do teenagers not use huge amounts of cocaine? I think it comes down to cost. Cannabis and cheaper drugs like ketamine or MDMA seem to be the drugs that teenagers turn to, and they're deterred by the cost of cocaine. So as people get a bit more money in their 20s, maybe they're more willing to step into that world. And Margaret's paper, I suppose, gives us clues as to who steps into that world, looking at both 17-year-olds and 20-year-olds. And maybe what struck me as a clinician dealing with primarily addiction issues is that maybe some of the findings in Margaret's paper challenge some of the ideas we might have as clinicians about who is really using drugs out there at the population level. One of the non-significant findings, I suppose, was the relationship with household income. And, even by the age of 20, if there was any vague trend, it seemed to be kids from richer backgrounds were perhaps more likely to be incident cases at that age, but it was non-significant overall. So the idea that deprivation is a huge driver of drug use at the population level maybe is something we need to reconsider. And the other issue is that as a clinician, I suppose I broadly welcome the increased attention that issues like dual diagnosis and trauma-informed care are getting, and the link that we would see between mental health problems and substance use. But Margaret's data sort of points almost in the opposite direction, that at a population level, in terms of people's entry into the world of cocaine use, it's not been driven by mental health problems. In fact, people with higher rates of mental health problems seem to be less likely to step into the world of cocaine use at the age of 20. Again, linking the data from the two studies, I suppose another thought relates to the age at which people were recruited into the Growing Up in Ireland study, which was, Margaret said, they were born sort of 97, 98. So if you think about Deirdre's data, where she's talked about the escalating problems that we began to see around 2011, our cohort in here were sort of just entering into their early adolescent years. They were sort of 14 or so at that time. So they were growing up in a population that was using increasing amounts of cocaine and using in an increasingly harmful way, and perhaps in homes that had year on year a little bit more money to spend as the economic situation improved. And I suppose, again, final thought just related to, say, that the links or the predictive factors at the age of 17 versus those at 20. And that maybe at 17, we see the influence of more proximal factors. So that is the influence of peers, which remained significant at the age of 20, but peer drug use was a more powerful influence at the age of 17. But family influence, parental substance use or family substance use problems were a bigger influence at the age of 17 than they were at 20. And perhaps at the age of 20, it's more global, wider influences that predict people's entry into this world, and perhaps it becomes a more normalized behavior, which again takes us to, hopefully, as we head into now preparing for a new national drug strategy, the issue of prevention will hopefully be a prominent component of that strategy. And the message from I think maybe Margaret's paper in particular is that we really need to take a population health approach to that really, it seems to be people from all sorts of backgrounds and circumstances who are vulnerable to stepping into this world. So they're my
Great.
thoughts.
Thank you, Bobby, for those insights. Yeah, absolutely. A few surprises in the evidence there, maybe some almost kind of things that make you recalibrate. So what is going on here? But I suppose stepping back and looking at that big picture, I'm curious to know, was any of our panelists like really surprised by, I mean, that figure of the 23% at 20 is quite shocking to me anyway. I'm just wondering, were you surprised by the magnitude of it in young adults that was coming out of the data? Margaret?
Yeah, absolutely. Yeah, I think the fact that nearly a quarter of participants reported past year cocaine use, especially in the context of potential underreporting of an illicit drug, was definitely very surprising and much higher than has been reported in other countries. Although not all of them have very recent estimates published. And the fact that it was corroborated by a survey that was performed in UCC, kind of gave further validity to our results. Even though that was within university students, they were of a very similar age range. And so, we thought it was quite interesting and concerning for sure.
Absolutely. And Deirdre, I mean, your data clearly show an ascent in the harm that comes from this as well. Again, were you surprised by that gradient, by the steepness of those curves?
Yeah, quite shocked, especially kind of around 2015 and onwards. The increases just keep coming, and while it does track, Ireland's economy to a certain extent, the rate of increase in since 2015 in particular, I think, is very hard to explain. And it's, and I suppose just go back to the point that Margaret said that, it's one of the drugs that you become dependent to most quickly, like 5 to 6% become dependent within a year. So are we seeing the harms quicker for cocaine than we would for another substance? Maybe Bobby probably could comment on that.
Bobby?
Yeah.
Well, I suppose as Margaret's slide, ranking drug harms across the various drugs out there, cocaine is definitely a drug that can cause more problems more quickly than most other drugs. Just to come back to the point about the prevalence, certainly I was really struck by the 22%. It did strike me as surprisingly high, but I do think it's important to turn these things on their head. 78% of people at the age of 20 are not using cocaine. It is past year use. The drug use in higher education survey that Margaret mentioned, which did report quite similar rates, it did indicate that cocaine use amongst users is on average about once a month. So it's not a wildly frequent behavior. And again, actually emphasized when people were asked why they use cocaine, by far the most common reason was for fun and to facilitate socializing. There was very, very few reporting coping-based motivations to deal with distress and so on as the reason for cocaine use. So yeah, worrying, but important not to start normalizing it completely. The majority of young people are not using cocaine, and those that do tend to use it quite infrequently on average.
Okay, although we can see that the harm relating to it is on the up and up. So so definitely there are consequences even to those types of use. Just to remind people that questions are coming into Slido. So
your sound just gone there.
In the chat there. Okay, so a couple of questions coming in. Are there residential beds in public hospital for psychiatric issues for children up to 18 years of age? Maybe Bobby, that's one for you.
So children admitted for psychiatric reasons are meant to be admitted to dedicated adolescent mental health units. They're not meant to be admitted to certainly to adult wards. In some cases where people need admission, they will be admitted to a pediatric bed. But if they're there for mental health reasons, ideally they'll be moved into one of the dedicated inpatient mental health facilities.
Okay, great, thank you. A comment here, there was a dramatic increase in cocaine during lockdown when organised crime gangs withdrew weed and flooded the market with cocaine, many women using too. So that's a comment from someone. No clear treatment options for cocaine use. Are HSE going to provide them specifically for cocaine? Is that something any of our panelists feel confident in saying something about?
The key treatment interventions for cocaine addiction are talk therapy and based approaches. Certainly, there's no medication, so there certainly is a challenge, I think, for all treatment services to sort of pivot away from certainly the Dublin-based services from a model which is very much focused on heroin, which had obviously methadone as a core component part to treatment, towards providing more psychosocial based treatment. So once again, as we look to the next national drug strategy, I would hope to see a growth in the provision of those psychosocial supports to deal with all I suppose the full spectrum of addictions, which include cocaine, ketamine, MDMA, cannabis, alongside the ongoing challenges with opiate use.
Okay, great. Thank you. Somebody says, appreciate the importance of a multi-factor approach to prevention. Any evidence in the Growing Up in Ireland about how we can engage with this age group effectively? Because obviously we need to engage with people in order to implement protective policies. Margaret?
It wasn't something we specifically looked at. But yeah, that would probably have to be a different research question.
That is fair enough. That is fair enough. Okay, let me see. Is crack cocaine in the overall data finding, and are there any plans to assess the crack cocaine issues among young people due to increased harms?
It wasn't separated out within the Growing Up in Ireland study. It was something we talked about at the times, but it wasn't possible to look at with our data. I'm not sure, Deirdre, if you had.
We didn't, because we couldn't do it for all the data sources, so we combined them together.
Okay, fair enough. We have a comment here. Anecdotally, I've heard stories about cocaine use being more prevalent among higher income populations than other drugs. Was there evidence of a class gradient? That's something we may have touched on already, but any comments?
Yeah, so we did look at socioeconomic status in our initial analysis, and we reduced the number of variables in our final model as we went on. I suppose, as Bobby's touched on already, we didn't see, I suppose, what would typically be touted as potentially more prevalent in socioeconomically disadvantaged communities. We actually saw potentially a slight association in the age 20, a slight tendency towards the higher socioeconomic classes. But yeah, it didn't retain statistical significance when other factors were considered. So,
okay, thank you. Is this data solely for cocaine hydrochloride use, or does it include crack cocaine? Oh, sorry. Okay, we've already answered that one. Thank you for your presentations. And said, so we have another comment about the psychiatric beds under 18. I think that's quite a specific one. Not available unless you can pay. That's okay. Keep your comments coming in on Slido if possible. Something that really struck me. Oh, sorry, Bobby, go on. Yeah, go on.
Psychiatric beds for under 18s are available. There mightn't be as many of them as psychiatrists would like to see, but there is a publicly available residential treatment option for the subset of young people with severe mental health issues who need inpatient treatment. Again, we'd like to see more, but there certainly are beds, and it's certainly not the case that they're only available privately.
Okay, great. Thanks for clarifying that. I suppose something that really jumped out at me, hearing your presentations and sort of reading the papers behind them, was the importance of early intervention, and that there are some factors that really do seem to be associated with an increased risk of later cocaine use, things like early exposure to alcohol and things like that. So what kind of message is there for policymakers there in terms of designing and kind of being aware of interventions that may help?
suppose I'll jump in. I suppose
Yeah.
what it really shows to me is that there is often a discourse out there that we don't need to worry about alcohol anymore because people are just using drugs instead, and it often gets lost, the link between alcohol in particular and cocaine use. I think in Margaret's study, the single strongest indicator of cocaine use at age 20 was early alcohol use. So I think it's really important to highlight that link, and that I know myself from doing population surveys that the majority of people, the first time they use cocaine, they had been drinking on that occasion. So the two substances, the use of them is very strongly interrelated. So we can't just look at cocaine on its own without looking at alcohol as well, I think.
And Margaret, was that something that came out very strongly from your data as well?
Yeah, so I totally echo what Deirdre said. I think it's just important to consider these things using a joined up perspective. You know, these factors clustered together. Early alcohol use was the strongest predictor of subsequent cocaine use. It is difficult to disentangle causality. You know, does one factor cause the other, or are they things that clustered together in certain individuals? But it's certainly important based on this data to take a holistic approach and a sensible approach to tackling them together rather than in isolation or regarding them as different problems, because we can see really clearly they do cluster together.
Great.
And it suggests to me that if we do take steps to delay young people's entry into the world of drinking, and that would probably involve targeting aspects of family, community, availability, promotion, and so on, and cost perhaps, that it could or should yield knock-on benefits in terms of then reduced drug use down the line. So I think that's a key takeaway.
Very good, very good. We are running out of time, but we do have time for one more question. Great presentations. Do you have any plans to add the data from the most recent wave at age 25 to your research?
I think potentially not me, but I'm sure somebody else will.
It would be a good thing to do. Absolutely. Absolutely. Great. Well, as I say, we are just coming up on time. So I just want to thank today's panelists hugely. So Margaret, Deirdre and Bobby, thank you so much for sharing your data and your time and your insights and your expertise. It's been a hugely valuable learning experience for me, certainly, and I hope for all our attendees as well. Just to let you know that this webinar is being recorded and will be available to watch back on the HRB's YouTube channel. And today's event is part of the wider Evidence for Policy series that the HRB has introduced this year, and it includes webinars, podcasts, videos and blogs, and they're all designed to help researchers and policymakers to understand each other's work practices better, and ultimately to help ensure that the right evidence is used to shape health policy and practice in the longer term. And I think we can see very clearly today some of the key messages that came out from the data. And these Evidence for Policy events will lead up to the HRB National Conference, which is about advancing evidence-informed policy for health and social care. And it takes place not too far away now. 3rd of December is when it's happening. So do keep an eye on the HRB website and social channels for more details of what's happening in the coming weeks. And Suzanne has just put some details in the chat there, I can see. But for now, thanks again to our panellists, Dr. Deirdre Mongan, Dr. Margaret Brennan and Professor Bobby Smyth, and thanks to you all for joining us today.
Thanks, Claire.
Thank you.